Good evening, everyone present here. I am Faraz from IJCP Group. Welcome all the participants on today's webinar. Let's welcome today's speaker with great honor, none other than Dr. Uni Krishnan Madhyapit sir. And let me share some of the achievement of sir. Sir has done MBPS, MS, MCH, FICS, FVSI, consultant vascular surgeon at SUT Hospital, Pantom, Trivandrum. And today sir is going to discuss very important topic, that is hybrid repair of aortic arc pathologies. So by taking not much time to know more about this topic, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Thank you, Paras, for that introduction. And it's a privilege for me to speak on this MedTalk forum. And I thank all the, your team members like Ankana, Ishika, who invited me for this. So, as we all know, aortic arch is the domain of aorta, which is very critical in the sense it provides blood supply to the brain and both upper limbs. Also, is the inflow for kidneys, spinal cord, lower limbs, and all the viscera down. So, these arch pathologies are not very common, but not uncommon as well. It will form about, say, 5 to 8 percentage of aortic lesions. As we know, it's the infrarenal abdominal aortic aneurysm, which is about 70% of all aortic lesions. So here, although it is comparatively rare, but it not, as I mentioned, not uncommon, but it's very dangerous if not optimally treated. So I'll take you through next 15 minutes or so about the aortic experience on arch that we have, in particular hybrid repair. How do I know? One second. Now, it's important to know that the aortic arch is divided into a few zones, which means zone 0 is that part of the aortic arch which bears the innominate artery, which means a lesion there, we have to treat mostly all the three branches of the aortic arch, which means basically the cerebral circulation and to the limbs. And in the in the first slide on your left is zone 0 to zone 4. But what critical zones are, it is zone 0 and zone 1. I say this because two reasons. Number one, when there is involvement of zone 0, we have to replace and debranch and proximalize all three branches into ascending aorta. Whereas if it's zone 1, we can still get the inflow from innominate artery. And on the picture on the right side, it tells you for a secure deployment of stent graft in the arch, you need a horizontal lie, at least 3 centimeters of proximal landing zone. I'll be alluding to this proximal landing zone. That's the normal area of the aorta we require for the graft to be inflated or deployed when we release it in the bloodstream. So anything short of 2 centimeter, it is unstable. It can migrate down, or it can create a type 1 endo leak, which is very dangerous. So this right picture shows you that it's zone 0 and zone 1. Those are the two placements for the deployment of stent graft, which is the component of the hybrid repair of the arch. Now, there are 4 basically important lesions of aortic pathology in this group. That is, one is atherosclerotic aortic arch aneurysm, which is, as the word mentioned, atherosclerosis. It happens in elderly, more than 60, 65-year-old, and it is a part of the generalized atherosclerosis in the body that man has. Now, second and equally important lesion is what is known as a Stanford B aortic dissection. Aortic dissection is where the blood enters into the aortic wall, forming a transmural hematoma, and it can split the aorta into two, into a true and false ligament, and can lead to what is known as malperfusion. Some of the viscera, including spinal cord, kidneys, lower limbs, or mesenteric, they may get out of circulation, and that again, the malperfusion is a very dangerous thing. Third is less common, is about 10% of all the Stanford A dissection which starts in the ascending aorta. There the problem is that the generally it is possible, although the split goes right down to the thoracic aorta, almost up to the aortic bifurcation, we will be treating only the aortic valve and the ascending aortic. In fact, this is the domain, not ours, it's the domain of cardiac surgeons. Basically it involves the coronary implantation aortic valve, which as vascular surgeons we don't do. In about 20%, 25% of the patients following Stanford A dissection treatment, the distal portion in the arch and descending thoracic aorta can go on expanding and give rise to the same phenomenon of enlarging false sac, false lumen, and it can threaten to rupture, which can be life threatening. Then, of course, the fourth one is aortic trauma. Most patients in a severe deceleration injury with high speed vehicles, I think they don't reach anywhere. They instantly they have a fatal end in the car or in the bus itself. Where only about 10% will reach. There, I think mostly we can deploy a stent graft. In our experience, only one or two patients required a hybrid procedure, which means we had to debranch the either the left carotid or the left subclavian. But by and large, the fourth is a comparatively rare situation. Now, starting with the atherosclerotic aneurysm, you can see that it's in the aortic knuckle. And for us to operate, we can get the suture line in open surgery at the end of left subclavian artery. But when we are talking about a stent graft and debranching, we have to at least come to zone 1. Now, this is the picture of a AP view. You can see how big the aneurysm is, lot of thrombus, and it extends into the concavity of the aorta much more than what we see in the knuckle. Now, in the aneurysms, the threshold for surgery is 5 to 6 centimeter. Generally, the literature says 6 centimeter or more, but I think in Indian context, many of the patients will be not so big, not so heavy. Their body surface area will be something like 1.5, 1.6 centimeters. So 5 centimeter is a threshold in our setting. Then symptomatic aneurysm, despite whatever is the size, and the sacral aneurysm, which is the enlargement only one tangent of the aorta, even as small as 2.5 can rupture. So we have to do the treatment what is required. Now, this is the aortic dissection. You can see that golden colored area is the split false lumen, and the inner one is the true lumen. The Stanford B means post subclavian, the aorta get torn, blood enters into the aortic wall, leading to the clinical symptoms. This is not as dangerous, as imminently dangerous as the Stanford A, because there can be pericardial rupture, there can be aortic leaflet damage, and there can be a compromise to innominate artery. So Stanford A is more dangerous than Stanford B, but the International Registry of Aortic Dissection, which explains the Stanford A and B together, according to them, about 30 to 35% of the patients die if we don't treat the aortic Stanford B dissection, which I'll be alluding more. Now, that split aorta comes right up to the left common iliac artery, all the way into the abdominal aortic bifurcation. Now here, malperfusion is an imminent indication of surgery because systems can fail, kidney can fail, the bowels can get necrosed, it's life-threatening. Otherwise, if there's no malperfusion, we can treat them at 3 months so that the patient will not go through all the syndrome of Stanford B dissection. In case, while follow-up with beta blockers and other medications, if you find that the false lumen is expanding rapidly, something like 3-4 centimeter from the beginning, or if they have a persistent pain and that's a rupture syndrome, and or if they have intractable hypertension, which may lead to rupture again. So these are the indications for treating early. Now, this is the third condition, third type of cases that we have to treat. You see the top picture on your left shows you the arch itself dissected following a Stanford AAB dissection. This happens only about 20-25%. The next picture there, you can see how small the true lumen has become, and there's no malperfusion, but that expanded in the near the knuckle of the aorta and upper DTA, descending thoracic aneurysm, which is going to be fatal if you don't treat the patient. Now, aortic injury, I've already alluded to. Now, the hybrid procedure, in contradistinction to the open procedure, totally open procedure, is not that stressful to the patient and comparatively less time consuming. And there is no need for circulatory arrest or cardiopulmonary bypass. Nowadays, of course, it's not complete circulatory arrest. We can always perfuse through an axillary cannula, clamp the innominate artery, have blood flowing to the brain at about 20 degrees or 19 degrees, up to about 200 to 300 cc of blood. That will support the brain with enough collateral circulation on either side. Then this is becoming a hybrid procedure, becoming a durable procedure. And then for extensive lesions, when you have to replace arch plus most of the descending thoracic aorta, I think we have to choose a hybrid procedure. This already I mentioned, and total endovascular is also a important component. But this is fraught with problem, because if there are a lot of clots in the arch, ascending aorta or in the descending thoracic aorta, a lot of this endovascular manipulations, putting the stent graft, making holes, and connecting the innominate, carotid, and subclavian artery through another side limb, that can produce a lot of embolism into brain, can be counterproductive. This again, hybrid is cost effective, and we have more reproducible results. And in our series, although I have done both arch aneurysm open and circulatory arrest with axillary cannulation, as well as hybrid, I think we have almost switched to hybrid aortic repair, because it has got, I will just talk about the components there. Now, okay, I think I missed one slide. I think the slides are running fast. How do I go back? Okay, 1 second. I got it. This is not. How do I control this? It's not moving well. I'm sorry. I'm not able to control this.
Hello, sir.
Yeah. See, this is moving faster than I think. How do I control this? It's not running proper.
Sir, you once you click on next, it will go next. Once you come back to that slide, you can keep it. Like once you click, then only it
No,
change.
still.
Which slide number, sir,
Okay.
you want?
Okay. I think now I have got the control. I'll
Yeah,
just
yeah,
come
sir.
back. Yeah, okay,
Correct, sir.
okay. Now this I finished, and this is the picture. I have shown you that all three branches are being given grafts from the previous graft, and then we have done a stent graft. So this is the treatment done for the residual dissection in the previous case I mentioned. This is an extensive case, arch with descending thoracic aneurysm, You can see that the yellow arrow and beyond up to celiac axis reaching, such a patient is very difficult to treat. And then we have used a hybrid procedure. And now you can see that ascending aorta to all three branches, the grafts have been given to the carotids, innominate, and subclavian. And we have used two stent grafts to repair the patient, and he has survived. And this is the front page of the Journal of Vascular Surgery. Now, some other picture. This is a patient with a complex ruptured aortic arch aneurysm. He came to us on 10th day, and then we had all these. Innominate artery was aneurysmal, and the left common carotid was blocked. And then we have only subclavian artery, which we took as a distalization from the thoracic aorta, grafted to subclavian, then subclavian to the right carotid patient. When I left about 5 6 years back, it was 3 years after surgery, and he was still coming for follow-up. My colleagues tell me from Sri Chitra. This is again a retrograde dissection, native de novo, and we have done this treatment with stent graft and ascending bicarotid and bisubclavian grafts. And this is another patient, 76-year-old, distal aortic arch and total descending thoracic aorta. You can see the pictures, and on your right, you can see that debranching we have done partial carotid to carotid and to subclavian, and two stent grafts, and then we have given a chimney to the celiac axis. I keep seeing him in the place where I work. This was done about 8 years ago. Now, this is another patient, 60-year-old man, who came with a ruptured aortic aneurysm. I think that picture is missing. Okay, this is another patient with dissection and expanding false lumen, and this is the treatment done. We have done a carotid to subclavian bypass and a stent graft repair. He is coming for follow-up on a regular time. Now, the prime indications, I would think, people who are more than 70 years, 75, multi-system problems, coronary, lung difficulty, and some minimal or moderate kidney disease. Of course, kidney, the stent graft also is going to be a problem with the contrast and CT scan, and then, but still much less than an open surgery. And then extensive aneurysm, and of course, the patient prefers minimally invasive surgery. We can give this hybrid arch. Now, we have two methods. One is when it's an elective procedure, we can do the debranching, by which I mean ascending aorta or right carotid, that is the innominate artery carotid, can be the inflow to revascularize the left carotid as well as left subclavian. We can do that in 2 stages, which is better in my view in elective setting, synchronous if there is any threatened or actual rupture going on. We have to keep a 2 centimeter proximal landing zone so that the stent graft keeps tacked into the aortic wall, which is normal. And we go for, as I already alluded, zone 0 or zone 1. And oversizing is 10 to 20%. I'll be alluding to this much later. Ballooning is done mostly for atherosclerotic aneurysm, and it's a little dangerous for trauma as well as dissection. Now, the time period is to 2007 to 2022. We started doing in 2007. I have a personal series of 152 patients, and grafts used. Some of the patients require 2 grafts for an extensive lesion. We have used it in 10 patients that way. And 78 patients are in the hybrid arch group to make a total of 152. And this I have already explained in detail. Out of the 78, majority has been, almost 2/3 have been degenerative aneurysm atherosclerotic. Next commonest is the Stanford B, and the other 2 varieties are not that common. A mean age of 70, from 36 to 78 is the age group, and predominantly male preponderant. I think there's one question is always there: what do we do with left subclavian artery? When we realign the aorta or put in a stent graft, deploy it in the aorta for a very extensive area, especially in the lower half, where there are intercostals are very prominent, supplying the Adam Kivix artery to the spinal cord. We have to have the vertebral supply, basilar supply, using the subclavian bypass, and then otherwise there is a high chance of paraplegia. And of course, when there is a right vertebral artery is not dominant or very small, we have to preserve basilar supply by grafting the subclavian artery. When there's a Lima graft, when there's a we have a um, hemodialysis going through the fistula and aortic origin of left heart. I mean, you have number of indications for must-do situation for left subclavian artery. Having said that, the problems with open surgery and to some extent endovascular is high, we have problems. We have lost patients, almost 8 patients out of the 78, just above 10%. So there's no free lunch. Elderly patient can have multiple problems and we can lose the patient despite a reasonably good 98% technical success. Now, there's been some amount of morbidity, renal dysfunction in 10, but they recover, ventilatory support, then, of course, stroke, which, of course, again, only one patient had a dense stroke, rest of them improved. Some minimal, the neck hematomas needing re exploration, wound dehiscence in the groin, and endoleak type 1 in 3 patients, which you have managed. Now, three out of the 3 cases, one patient we did a necklace procedure with TIVA add-on, and then there's another patient where we used a second endograft, and one patient while waiting, he didn't have sufficient money. He came much later, and then I think he didn't. I mean, as I said, we could not give him a free graft. It's about 3-4 lakhs at that point of time, and he died while waiting. Now the follow-up is we follow them up at 1, 3, and 6 months, and thereafter yearly. CT scan is a must either at the time of discharge from the hospital, if everything is okay, the renal function is good. Otherwise, we do it within 2 to 3 months. That's the basal CT. That is depicting the surveillance for the patient. Then, of course, later on, maybe 2, 3, or 4 years later, then what I do is we don't do CT scan because each CT scan in our setting 128 X-ray radiation and quite damaging to the kidneys. And we have had 1 or 2 patients going into renal failure with repeated scans. So we do it very carefully. What we do is we check the blood pressure, we look at the pedal pulses, and we do an ultrasound and we do a chest X-ray AP lateral. If the earlier X-rays and if the patient is comfortable, we don't do as frequent as many other centers. Then, of course, in follow-up, we have had mortality. What was worrying in our setting is that we have had one patient died after 10 days of discharge, maybe something wrong with type 1 endoleak or something. 4 patients with good quality died at varying times, 6 months, 8 months, 3 months, and 4 years, because I think there was no problem with CT scan. Everything looked well, but they died, I think, maybe we missed out small endoleak, or because more than that, we feel we were oversizing like the literature 20%. That must be pressing onto the esophagus or left bronchus or trachea, and then patient developed hemoptysis. Another patient, 79-year-old, died with Alzheimer's. Now that is a look at systematic review and meta-analysis of hybrid as repair. The one Italian surgeon called Mulakakis in 2013 he has looked at 26 studies with just under 1,000 patients, 30-day hospital mortality 11.9%, and he had significant stroke and paraplegia, together almost 10%. Now, the lessons that we have learned, what personally I have learned, it's not enough to go 2 centimeter, it is to go 3 centimeter, because unlike the surgical graft which we stitch, here we are not stitching. Just by the axial force, it is remaining stuck to the aortic wall, which has to be normal. So whatever we have to come in, it's coming in the way, we have to give a surgical graft, we have to debranch them appropriately. We debranch sufficiently to get a 3 centimeter proximal landing zone, 2 centimeter only distal landing zone, and appropriate debranching is done, which makes it a very stable, very safe procedure, so that the no system dysfunction occurs. And we do not go to zone 2, zone 3 near subclavian artery, because that's immediately a vertical flow of blood, and hypertension can produce migration. And in some cases, there's a French report which says that there has been 4 out of 16 had the retrograde aortic dissection. So the graft has to lie down horizontally 3 centimeter proximal. We can't afford to have repeated grafts, and then the cost is now 6 lakhs per piece. And of course, hybrid repair, we have found good and durable results. Now, oversizing, I think last so many 10, 15 cases, I have oversized 10% for atherosclerotic aneurysm, only 5% in dissection and trauma. The nitinol, which is forming the skeleton, metallic skeleton for the surgical graft outside, it can expand almost 10 to 20%. So we don't have to oversize. In our patients, the delayed death which has occurred, uh, 2, 3 patients, I think it's because of our too much of oversizing. Now, I think to summarize, I would say that open surgery still has a role. 60, 65 years of patient with good risk system, I mean, their systems, and no coronary or lung or kidney problem, they can still undergo open repair. Open is still gold standard, but hybrid is what we prefer mostly because they're elderly, they have some problem or the other. It's an extensive surgery, circulatory arrest, brain problem, system dysfunction, and all that. You heard medium, now it's long-term results with hybrid arch, and we need a focused planning, multi-system arrangement, good anesthesiologists, radiologists, and a very focused situation. In our series, we have not had a single retrograde arch dissection in this situation. Now, I reiterate, unless what the literature says, we need to have a proximal landing zone 3 centimeter. We found that is safe. Deploy only zone 0 or zone 1 with a horizontal line in the arch. Stent oversize 6 to 10%, not 10 to 20%. And hybrid surgery has had less complications, but that procedure also has complications and initial follow-up in few months. And we don't repeatedly do CT scans for fear of radiations and renal dysfunction. Now, on this subject, hybrid arch, in 2022, we have had in the Indian Journal of Vascular Endovascular Surgery, we have published a 11-page article on 75 patients who have had hybrid repair. Those of you who would like to go through, you can. Then we have got good case reports, complex case report in Journal of Vascular Surgery, which has come as front page in the journal. Then we have Asian Journal of Cardiovascular Surgery and Journal of Cardiovascular Thoracic Anesthesia by our department. Now, that's my teacher and mentor. I owe it to him for what I have reached in vascular surgery. That's the Sri Chitra Institute, where I have done 71 hybrid arches. That is my alma mater. I'm indebted and grateful to all my colleagues there. Now, the present SUT hospital, which is also in Trivandrum, just a kilometer and a half away from where I used to have my 35 years of training and further almost the entire professional life so far till I reached retirement age. And now I'm at the private hospital trying to do as good vascular help to patients as possible. So sorry, gentlemen and ladies, there's some hitch in the in getting the slides ready and getting the internet connected and things like that. Sorry about that. And thanks very much, MedTalk group, Ishika, Ankana, and Varas. I think thank you very much. But for you, I think this could not have happened. I have missed out some 10, 12 slides, but I think now we don't have to go back. I think probably the listening doctors would have had some idea. I think then they can easily look at my literature, that Indian Journal to 2022. That will give a reasonably good overall picture how we have practiced about hybrid aortic arch repair for arch lesions at Sri Chitra and at SUT. Thank you so much. Thank you, everybody.
Thank you so much, sir, for your valuable time and sharing your knowledge on this topic, sir. I definitely think this session knowledge is going to help all the participants who have joined this session. Sir, we have received some question from the participant. If you allow, with all your permission, shall we take these questions?
Yeah, sure. Sure.
The first question is Dr. Subramaniam. He is asking what are the key indication of hybrid repair of aortic arch pathogenosis compared to traditional open surgery?
Yeah. In fact, I have alluded this in my talk. Um, open surgery is gold standard, no doubt about it. If the patient is 60 years or younger with good physiological systems, normal heart, normal lung, and this thing, this may be little rare, but we do find. So for them, it is open surgery is better because it is durable procedure, it the surveillance is not difficult, and it is proven 30-40 years patency for the graft. In contrast, elderly patient like 70, 75, or 80, I think above 75, I have decided that I will never think of doing open, because according to the national population in Kerala, the male life expectancy is 74, female 76. So that's not the way to go for an open surgery with all attended problem with brain and all systems, and technically long procedure. It's very, very stressful, not only for the patient, to some extent to the surgical team as well. So hybrid procedure, a little more control. We need a thorough planning and combine the surgical, open surgical to debranch and endovascular for stent graft deployment.
Thank you so much, sir, for sharing your insight on this question. We have another question from Dr. Agarwal. He's
Yeah,
asking what are the potential complications associated with hybrid aortic arc repair and how can they be mitigated?
yeah, good question. See, there are very severe complications. There are minor complications. Minor complications I mentioned: transient increase in renal dysfunction because of the contrast, then some wound problem, and so those are the minor complications. Two or three major complications are: number one, we are back to back, maybe with 15-20 minutes of gap, we are clamping the carotid vessels. I'm talking about pan or total debranching. So that can lead to sometimes minor or even major stroke. I remember one 65-year-old lady, we did debranching. We had to do a pan debranching, and she developed a dense stroke to the extent that she was almost immobile. She could not use the hand. Then I gave up on the second stage because I thought, since she has got so much of stroke, we send her. She never came back for surgery. So major stroke, cerebral stroke is one. Then paraplegia can occur, but paraplegia will be definitely less than open surgery or otherwise, because what we have to do is we have to carefully choose to revascularize subclavian artery in case of dissections. See, there are in paraplegia, there are four segments of blood supply to the spinal cord. One is both vertebrals and basilar for cervical cord, intercostal for thoracic, and abdominal portion is the iliacs and lumbars. So, if any one side is uh, upset or blocked, there need not be paraplegia, except the lower half of large intercostals, including the Adam which is present from T6 to L1. So if that part alone is changed, we invariably say that 1 to 2% chance of paraplegia is there. We give all medications, we do a CSF drain. That has helped us in improving the chance of success with from paraplegia. Third component is the endoleaks. If the patient's type 1A endoleak, that means when blood leaks between the graft and aorta or aneurysm from the front, from the ascending aorta arch, those patients can die within weeks or days, because we have closed off the outflow distally and the blood is entering. If that aneurysm can rapidly enlarge, and so that has to be very clearly identified, and immediate action should be taken, whether you find it in cath lab or find it in the first week CT scan or a month or two later. That's why one patient waiting for a month, he died because he didn't have money to come and get the graft for the surgery, and he didn't survive. So when there is a type 1A endoleak, it's synonymous with emergency, worse than having the aneurysmal disease, because it can soon rupture, and it can be a life-threatening rupture that way. So these are the common major problems that can have. Then of course there will be type 1b endoleak, type 2 endoleak. But in arch we have not found much of type 2 endoleak. We have not found out 1b endoleak. Rare. It's generally the endoleak system is a problem of abdomen, not so much of the thoracic aorta or arch.
Yes, sir. Thank you so much, sir. It was really wonderful and you explained this question very well. I hope this will be helpful to all the audience also and the participant who have asked this question. Sir, I can see there is no more further question. I hope that you have done justice to this topic, sir. And Dr. Ramakant is writing wonderful session and very well presented.
Thank you so much.
Welcome,
Thank you,
sir,
sir.
and
I
take care,
think,
sir.
yeah, I have a request to you that I think I need a tutorial previous day.
Yes, sir. Sure, sir. We will help you out so that we can't face any
Yeah,
technical
because what
issues
happened,
further.
I have almost learned how to manage till today. Because initially, one or two times I had hell of a problem, and we
Sure,
have abandoned after four slides.
sure, sir.
Now,
I will
this
help
I
you
didn't
out, sir.
expect. It's just going here and there. And tell Angana and Ishika, thanks very much, your colleagues. And it's a good opportunity for me to share on,
Thank you, sir.
hybrid arts, and I appreciate your help.
Thank you. Welcome, sir. And we would like to see you in future also. Till then, take care
Yeah,
of
sure
yourself.
thing. In fact, I have
Bye.
given a list of my wishful thinking, that what I can present another four five. I think whatever is, it's a little more common, little more less complicated. So that I think you can choose and let me know. But only with a tutorial I will take part next day.
Sure, sir.
Okay.
Sure, sir. Thank you.
Okay, thank you.